Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, recently we saw two guidelines, one from the Chinese last year and second from WHO this year on the management of chronic hepatitis B. These two guidelines presented new algorithm for the treatment of chronic hepatitis B in an attempt to achieve the WHO goal of 2030 of hepatitis elimination. A couple of weeks ago, I shared the management of hepatitis B in 2024, and I discussed these guidelines. Then, 2 weeks ago, I published another vlog where I discussed the hybrid algorithm with you people. I received many requests, wishes from my colleagues and from my PGs to focus on the new algorithm and discuss this in more detail, so the approach to the treatment of hepatitis B in a simplified form, which I advocate, becomes more clear. So in today's vlog, we shall discuss the simplified form of algorithm for chronic hepatitis B. This is the hybrid algorithm where I have combined the Chinese algorithm and the WHO algorithm in an attempt to make it more simple and to include more and more patients of chronic hepatitis B into the treatment. Let's go to the discussion. Let's start our discussion on the new treatment algorithm for chronic hepatitis B in 2024. We noticed a plethora of guidelines over last 10 to 12 years, where we see that almost every year, new guidelines were published by one of the four major organizations of hepatology, that is the AACLD, EASL, APASL, and WHO. But this is these last two guidelines of Chinese guidelines in 2023 and WHO guidelines which were published on 29th March this year, which has really changed the paradigm shift. And today we shall discuss how we can translate these guidelines into everyday clinical practice. As I said before, we see a paradigm shift of 180-degree in the light of recently published two international guidelines, the Chinese guidelines of 2023 and WHO guidelines of 2024, in an attempt to achieve 2030 target of hepatitis elimination from the world. We know that clinical guidelines, these are tools of management, not rules of management. So we take help from these guidelines to manage our patients in our clinical practice. We need to translate these guidelines into everyday clinical practice. We need to individualize, tailor the treatment as recommended by these guidelines to our patients. So what I'm doing in this presentation, I'll be sharing with you the treatment approach, step-by-step approach, that how should we manage our patients, and this will be purely dependent upon what has been recommended by these guidelines. And I call it the JIFS hybrid treatment algorithm. Javed Iqbal FAROOQI's hybrid treatment algorithm. When a patient is found to be having HBs antigen positive, when patient comes to you with test showing that he or she is HBs antigen positive, how should we proceed? This is the main question. That patient has been found to be HBs antigen positive, he or she was donating blood, or just on screening, pre-visa screening or pre-job screening, the test was done and found to be HBs antigen positive. So how should we proceed? First of all, we should check if there is any co-infection. We should check for the hepatitis D antibodies. We should check for HCV antibodies. And desirably, we should check for the HIV antibodies. Because the risk of transmission of these viral infections is parental route, and the risk factors are more or less similar. And we do see in our clinical practice hepatitis B and D co-infection, hepatitis B and C co-infection, hepatitis B, C, and D triple infections, and hepatitis B and HIV co-infection, and hepatitis C and HIV co-infection. So the first test which you should do after having a report of HBs antigen positive of any patient should to screen for hepatitis D, hepatitis C, and desirably for HIV as well. The patient may be positive for HDV, so it will be hepatitis B and D co-infection. But the patient may come out to be HCV positive, where it will be then B and C co-infection, or HIV may become positive, or any two or all three may become positive. So suppose we have checked these and our patient is negative for hepatitis D, negative for hepatitis C, and negative for HIV. So what should do next? What is the next important test which I should do for this my patient, so to proceed further? So what we should do is serum ALT levels. So patient was HBs antigen positive, and we checked no co-infections were found, or if co-infections are found, but practically for the purpose of discussion we say no co-infection was found. So the next test which I'll do will be serum ALT levels. And remember that in the recent 2024 WHO guidelines, the upper limit of normal of ALT for adult males and adolescents, the boys, it is 30. And for female and girls, it is 90. Female women, ladies, and girls, it is 19. So for male, 30 has been suggested to be the upper limit of normal, and 19 for females as an upper limit of normal by these recent WHO guidelines. And this is in an attempt to include more and more patients into the treatment. So the first test which we should do should be the serum ALT. And this may be raised or this may be normal. So we can have two types of patients now: HBs antigen positive patient with raised serum ALT and HBs antigen positive patients with normal ALT. So what should we do now? What these guidelines suggest? I'll refer to the WHO 2024 guidelines. As said, they were published on 29th March this year. And the algorithm the WHO suggests that treat all adults and adolescents aged 12 years or more, including pregnant and non-pregnant women and girls of reproductive age. And these guidelines, they give us four options, four scenarios. The first scenario is that if a patient has got significant fibrosis, that is F2 or more than F2, or cirrhosis F4, then regardless of the HBV DNA or ALT levels, you treat that patient. And then the second option is R, when the DNA level is more than 20,000 and ALT level is more than normal. It means more than 30 in male and more than 19 in female. Or the third option is when there is a presence of any of the following, regardless of the liver status or DNA level or ALT levels, if there is co-infection with HIV, hepatitis D or HCV, or if there is family history of liver cancer or cirrhosis, or the third scenario is when there is immune suppression, or there is comorbidities like diabetes, or metabolic dysfunction associated steatotic liver disease, or there are extrahepatic manifestations, or glomerulonephritis or vasculitis. So when these three scenarios are there, when these three options are there, you treat that patient. And the fourth, which is very interesting and which is important for me and which I want to refer and which I have highlighted in red, is that in the absence of access to HBV DNA assay, when you cannot do hepatitis B PCR, or there is no access to it. So practically, in the absence of hepatitis B PCR, this will be the clinical implication. Persistently abnormal ALT levels alone, it is sufficient to start your patient on antiviral treatment. So, which I discussed with you, that after the HBs antigen positive test, I shall do the serum ALT levels, and I will have two types of patients: HBs antigen positive with ALT raised more than 30 in male or more than 19 in female, and second, with normal ALT, where in male it is less than 30 and in female it is less than 19. So two types of patients, raised ALT and normal ALT. And the WHO fourth option is if there is persistently abnormal ALT levels, this ALT is raised on more than 2 times, on more than 2 occasions, at least over last 1 to 2 months, I will start these patients on treatment. So what comes here? In this group, HBs antigen positive patient, ALT is raised, treat this patient. Even in this case, no need of PCR, as the fourth option of WHO is that there is no access to BPCR and my patient cannot afford that, or if because no provision is there that persistently raised ALT levels in the absence of any other cause, it is sufficient criteria to start my patient on antiviral treatment. And this will bring more and more patients into the treatment. So, going to the second group, HBs antigen positive patients and ALT normal. So what is the next step? How to proceed? Again, I'll refer to these WHO guidelines. What they suggest, the first option was when there is significant fibrosis or when there is cirrhosis. It means liver status is either having significant fibrosis or cirrhosis, regardless of the DNA levels, positive, negative, whatever the level is, and the ALT raised or normal. The raised ALT has been covered by the fourth option, treat that patient. and the normal ALT, or if there is presence of any of the followings. I discussed all these with you: the co-infections, family history, immune suppression, comorbidities, extrahepatic manifestation. Here again, the DNA level becomes irrelevant and the ALT levels becomes irrelevant. We are talking about a patients with normal ALT, because the raised ALT has been covered, that the HbS antigen positive patient with raised ALT, start that patient on treatment. And this is according to WHO 2024 guidelines. So for the next step, ALT is normal. How should I proceed? So if there is fibrosis, cirrhosis, are these peculiar scenarios, and even the Chinese guidelines, the 2023, again they say as well that if patient has got HbS antigen positive and there is liver cirrhosis, liver failure, hepatoma, liver transplantation, if the patient is receiving chemotherapy, targeted therapy, and immunosuppressant therapy or DS treatment for HCV, then patient should be offered treatment. And PCR is not over here. So keeping in view these two aspects are in the light of this Chinese and WHO guidelines, what should I do? I'll go and I'll see if my patient fits in here. Number one, if there is need to prevent reactivation of hepatitis B virus infection. And when the need arises, when the patient is going to receive chemotherapy, targeted therapy, immune therapy, or if the patient has got liver transplantation. So in this scenario, there is a need, if the patient is HbS antigen positive and ALT is normal, there is probably need to prevent reactivation of HBV infection. Second, if there is extrahepatic manifestation, the glomerulonephritis or vasculitis. Third is when there is co-infection with HIV. Fourth is when there is family history of liver cancer or cirrhosis. And fifth is comorbidities with diabetes or MASL, and the liver status if the patient's liver has cirrhosis, significant fibrosis, HCC, or liver failure. So HbS antigen positive patient, normal ALT, I'll see these 6 scenarios. If the scenarios are present or if the scenarios are absent. So if HbS positive patient with normal ALT and any one of these scenarios are present, I will treat this patient. I haven't done the PCR, but the patient HbS antigen was positive, ALT was normal. If the ALT would have raised, I would have started the patient on treatment irrespective of these scenarios. But when the ALT was normal, I checked for these 6 scenarios. If there is any need to prevent reactivation of HBV infection, if there are any extrahepatic manifestation, if there is co-infection with HIV, is there family history of liver cancer or cirrhosis, if there is comorbidities, or if the patient liver status is showing liver cirrhosis or significant fibrosis or HCC or liver failure. If any one of these scenarios is present, treat that patient. If these are absent, then this is the group where you need to check the PCR. So don't jump on PCR straight away after you get the HbS antigen positive patients. First, look at the ALT and decide if the patient needs treatment or not. If it is raised, patient needs treatment. If it is normal, look for these 6 peculiar scenarios. If any one of these scenarios is present, treat. If not, then do the PCR. So the next question comes, should it be the quantitative PCR or qualitative PCR? We saw that the WHO is suggesting the quantitative PCR in the viral load of thousands, but the Chinese guidelines, they are recommending the qualitative PCR. And I will go for this qualitative PCR. The reason is, one is the cost, one is the there's a data that even the less than 2,000 copies, they do have the risk of patient developing cirrhosis and patient developing liver cancers. And I have discussed this data in my earlier vlogs, that what is that data which says that if the patient's viral load is less than 2,000, even in hundreds, it carries the risk of developing cirrhosis and hepatocellular carcinoma. So in keeping view of that data, and as recommended by the Chinese guidelines, I will personally go for the qualitative PCR. So we are in the third step. ALT was normal, so I didn't start the treatment. Then I looked for the 6 specific scenarios. They were absent, they were not present. So again, I couldn't start treatment. Then I checked the PCR, and that was the qualitative PCR. So when we check the PCR, there's 2 possibilities. Either the PCR is detected or the PCR is not detected. Definitely, either the PCR can be positive or negative. So here, no concerns, no worries about the viral load, whether this is more than 2,000, less than 2,000, more than 20,000, 2,000, hundreds. Because as I said, data is there. And I've shared that data with you in the previous 2 vlogs, that even less than 2,000 units, even hundreds, they do have the risk of patient developing cirrhosis and hepatocellular carcinoma. So just the PCR positivity is enough. So if the patient PCR is positive, I will start this patient on treatment now. So be with me. Our patient was age-based citizen positive. ALT was normal. So I didn't start treatment. I checked for these scenarios, and none of these scenarios were present. So I checked the qualitative PCR, and that turned out to be positive. So the age-based citizen positive patient with normal ALT and qualitative PCR detected, I will start this patient on antiviral treatment. What if the PCR is negative? Patient is age-based antigen positive, ALT is normal, no peculiar scenarios, and the PCR is negative. So here comes another parameter. That is, if my patient age is more than 30 years. And second, if my patient has got co-infection with hepatitis C or hepatitis D. I shall check for these 2 main parameters, main risk factors. If my patient is more than 30 years, or if my patient has got co-infection with hepatitis C and D, so if any one of these scenarios is present, I will treat. If my patient age is more than 30 years, PCR is negative, but age-based antigen is positive, LT is normal, I will offer the patient treatment. Because age by itself is a risk factor for the patients developing cirrhosis and carcinoma, and these has been defined risk factors in the EASL 2017 guidelines. Though they didn't say for the negative PCR, but we know that PCR is a very dynamic source of test. Today negative will be positive tomorrow. So if the age is more than 30 years, I will start this patient on treatment. If the patient age is not then more than 30 years, but the patient has got co-infection with hepatitis C or D, again the patient needs treatment. If the patient has got hepatitis C, so it's a BC co-infection, B inactive in terms of B PCR negative, C PCR positive. So I will start that patient on an anti-HCV drug, along with that hepatitis B drug, and till those 3 months, which is treatment for HCV, and then at least 3 to 6 months after the end of cessation of or the stopping of the HCV drugs, and this will be to prevent reactivation. And if the patient is, God forbid, non-responder to HCV therapy, then of course that warrants continuation of the hepatitis B drugs. And if the patient is co-infection with hepatitis D, then of course, when I'll treat the patients with the interferon, the interferon is the drug of, has been the drug for hepatitis B as well. But during that time, I will go for the oral drugs as well for hepatitis B. So this is one category when age is more than 30 years, or if there is co-infection with C or D. When even this is not there, so in this group, I will do not treat this patient, and I will do the 6 to 12 monthly follow-ups. So dear colleagues and PGs, this is a simplified form or hybrid treatment algorithm, which I suggest. And to me, it is more simple. It is more practical. It ensures more and more number of patients, more and more hepatitis B, HBs positive patients to bring them into the treatment, because what we have seen, negative PCR today becomes positive PCR tomorrow. And we have seen the ALT levels, they are not mostly the same, they are fluctuating. And we have seen patients with negative PCR, they're developing cirrhosis and they're developing a tumor. So to summarize, this was a treatment. Most of the times I used to follow this treatment, but because it was not recommended by the guidelines, so I used to kept it at times, or I used to tailor this approach to my patients in my clinical practice. But when these guidelines have been published, it gives me opportunity to share this algorithm, this source of algorithm, which was more or less the same, in more clear defined way with you people, that if you adopt this source of algorithm, which is purely based on the guidelines, nothing out of the guidelines, and the data. So if you follow this, you will include more and more patients into the treatment. So to summarize, a patient with HBs antigen positive, test in his or her hand, check for the co-infections of hepatitis D, C, and HIV, and then check the first test, look at the ALT levels, and then remember ALT levels is 30 normal for male and 19 normal for female. If the ALT is raised, start this patient on treatment, no need for the PCR. If the ALT is normal, then look for these 6 scenarios. If the patient needs to prevent reactivation of HBV infection, if there's any extrahepatic manifestation, is there co-infection with HIV, if there is family history of liver cancer or cirrhosis, if there's comorbidities like diabetes, fatty liver, if there is liver status, liver is cirrhotic, liver has got significant fibrosis, HCC, or liver failure. So out of these 6, anyone is present, treat that patient, no need for doing PCR. If all these are absent, then do the PCR. And what I suggest is the qualitative PCR. If the qualitative PCR is detected, so the qualitative PCR, normal ALT, treat that patient. If the normal ALT, negative PCR, then look for these 2 main risk factors, age more than 30 years, if there is co-infection with CRD, then this group again needs treatment despite the negative PCR. But if these risk factors are absent, patient PCR is negative, ALT is normal, then don't treat this patient. Put that patient on 6 to 12 monthly follow-ups and see if time comes when the patient ALT starts rising, or if God forbid there's other scenarios comes, or if the patient age is more than 30 years, he was younger, but later on the patient age was more than 30 years, then again it will reach into the group where you will offer this patient's treatment. So I end here, and I hope I was able to explain my suggested hybrid algorithm, which is purely based on these 2 guidelines. And I will request that please share your comments, share your suggestions, share your experience regarding the hepatitis B virus treatment. And remember that we are in an attempt to achieve the 2030 goal of WHO of hepatitis elimination. So I end here. and I'll wait for your kind comments and your any queries if you have got. So in the next session, we will be dealing with all that. Take care. Goodbye. Khuda Hafiz.